My name is Tom Potter, and on behalf of my co-chair, Dr. Wakili, and myself, it's my great pleasure to welcome you to this Biomed webinar on the role of mechanical circulatory supporting complex VT cases. The first half of the webinar, we will provide you with an overview of what hemodynamic support is and how to set up a complex VT program support in practice. And then in the second half, we will get insight from two expert users, Dr. Ramana and Dr. Silitorak from The Hague and from Rotterdam University, who will show us illustrated cases on how this all works in practice. During the presentations, you're most welcome to send questions through the chat function. And let's dive right in, and I'll share my screen with you so we can go to our first presentation. There we go. You should have that on screen now. And what I'd like to do is spend 15 minutes with you going over why it is we do this hemodynamic support and what, from a high-level perspective, it involves and what our experiences are with hemodynamic support. So these are my relevant disclosures for this presentation. And the clinical problem we're trying to face, of course, is that we would like in VT to map and ablate arrhythmias as we do with other reentrant phenomena, which means we would like to be able to study the ongoing arrhythmia and to map and ablate the ongoing arrhythmia, as you see in this example, where you see a nice evolution of diastolic potentials in the whole VT cycle, allowing the operator to identify the critical isthmus. And as you can see from this slide, this is a pretty old image. I made it when I was a fellow in Hamburg quite some time ago. And this is how VT ablation originated, of course, when there were no alternative concepts. The problem with this approach, or the limitation of this approach, is that recurrence rates are high and that the feasibility is low, due, of course, to the fact that most VTs are hemodynamically unstable. This is what it looks like in real life, in practice, if we can map them. So typically, what we can do nowadays is, if we already know where to look for in an identified substrate, and you can see here a pretty large scar in the left ventricle. If we go to the edge of that scar and we induce VT, we have a decent chance of identifying these beautiful late potentials as you see them on the top right of the screen. And typically, of course, this is feasible in patients, as in this example, with relatively slow VTs. This is cycling 500 milliseconds, so this is relatively well tolerated. And in these patients, we can get away with inducing VT for a few minutes, even with general anesthesia. It may be difficult even for slow VTs, but then we can find these beautiful potentials, as you see it here, perfectly mid-diastolic, and we can ablate the mid-diastolic potential in the ongoing VT, and then hopefully, of course, have an acute effect and terminate the VT. And why is it that we're happy or we're enthusiastic about chasing this endpoint? This is, of course, because it's a very useful endpoint, because there's good established data. For example, this from Bill Stevenson's group that looked at over 100 redo procedures from their database of 400 VT ablations, where they identified predictors of recurrence, and they found that a good pace match by itself, for example, is not a particularly useful indicator for a successful ablation, and non-recurrence was actually associated with non-inducibility, with the ability to identify a exit or isthmus site, and impartiated with RF termination, with early termination during ongoing VT, which has clearly the best odds ratio for successful ablation. So the rationale for support is, of course, that on one hand, you have the problem of recurrent drug refractory ventricular tachycardia, for which clearly established evidence shows that RF ablation is capable of providing VT suppression and long-term arrhythmia control, as identified in multiple randomized trials. But obviously, these patients are often high-risk patients, are complex patients with structural heart disease, with a strong set of comorbidities that make these procedures challenging. And preemptive mechanical circulatory support can clearly increase the safety profile of these procedures, identifying those patients of high risk of peri-procedural deterioration and preventively helping them, supporting them with support. However, due to complexity and costs of this approach, currently it is typically reserved to the very specific population of those patients at very high risk. The indication, I would argue, is that in the concomitant presence of advanced heart failure and multiple comorbidities, substantial management challenges are present in VT ablation, both during the procedure as well as post-procedural. And it's pretty well established that any acute decompensation and acute hemodynamic deterioration is associated with an increase in post-procedural mortality. And typically what will trigger these acute decompensations are the induction of anesthesia, the use of programmed stimulation, the presence of fluid overload, can, of course, trigger acute decompensation, which will then be a risk for triggering end organ ischemia, end organ hyperperfusion of the brain, the liver, the kidney, with all the resulting complications you might imagine. As clearly shown in this study from Sant'Angeli, if you look on the image on the right, the survival curve on the right, comparing those patients that experienced acute decompensation during their procedure versus the patients that did not, have decompensation in a solid line, you can clearly see that the post-procedural mortality is significantly increased in those patients experiencing decompensation. And the clinical factors precipitating this acute hemodynamic decompensation are factors such as advanced stage ischemic cardiomyopathy, severe heart failure, presence of multiple comorbidities, presentation with VT storm, and the use of general anesthesia in itself, which of course very much lowers the tolerance of patients for any type of ventricular arrhythmias. Identification of these patient profiles may make mechanical circulatory support a reasonable idea, in particular if a substrate-based ablation approach is not useful or is not feasible, as we'll see in a second. And these patients are indeed identifiable. A certain risk profile or risk score can be attributed. A particularly well-studied example of a risk profile for early mortality post-procedure is shown here, also from Sant'Angeli, where you can see what is called the pain ESD score, pulmonary disease, age, cardiomyopathy, heart failure, ejection fraction, VT storm, and diabetes, or all contributing to a score in this pain ESD score where a threshold of 15 or more indicates a substantial risk of early mortality. And in this particular study, an early post-procedural mortality was observed in 5% of patients, more than half of them while still in hospital. Risk factors for early mortality being low ejection fraction, chronic kidney disease, VT storm, and recurrence of VT, as we've seen before. And also, of course, interestingly and intuitively, once you start thinking about it, the presence of unmappable VTs. If unmappable VTs are present, you can expect, of course, a clearly increased rate of procedural failure, an increased rate of VT recurrence, and thereby potentially an increased rate of procedural or early mortality post-procedure. What is the available data on prophylactic support to avoid these phenomena? This is a meta-analysis from last year, looking at about 400 patients, 400 procedures, actually in just under 400 patients, where temporary mechanical support was provided, most commonly using the Impella system, and in a subset of patients, the tandem heart system, where the authors report the most common complication of the use of this system being procedural bleeding, and where they also report that in 6% of patients where a support system was not planned to be used, in 6% of patients, the procedure ended up needing a rescue implantation of a hemodynamic support system. In this meta-analysis, the authors report that preemptive implantation of an Impella or tandem heart device allows, obviously, as you might expect, a much longer time of sustained VT being present, allows induction of more VTs that are much better tolerated by the patients, and thereby, of course, in these procedures, on average, an additional 8 to 16 minutes were dedicated to implanting the system, which led to an average of 24 minutes spent on mapping those VTs. So almost half an hour of mapping time was gained by the implantation of an Impella device or a tandem heart device. Mostly beneficial if we look at the outcome, mostly beneficial in non-ischemic cardiomyopathy patients. The impact on the procedural outcome is mixed, as you see on the bottom, and only one study that focused on these non-ischemic cardiomyopathy patients showed a clear benefit for the support system. If we look at VT recurrence, we see that the use of a support system was not particularly associated with VT recurrence, and that early mortality showed a borderline benefit in favor of a mechanical support system. At long-term follow-up, the difference becomes significant. In this meta-analysis, a significant outcome benefit was shown for the use of a mechanical support system, of course, in non-randomized settings, of course, not having the benefit of a randomized study. And this is another interesting available report that looked at 19 studies and reported on patient profiles, patient demographics, and where you can see that in particular for the adult population, which is pretty much the scope of my presentation, for the adult population, 15 studies, 2000 is probably a stable procedure or a patient with a priori high risk. And you can see in is coming true, but what you can see is that the authors report benefits and downsides of both these approaches. Obviously, the benefit of not using a system is that you are not exposing the patient to potential complications. But of course, the main benefit of using a system is that there is a very sharp increase in procedural efficacy, and that in elective circumstances, complication rates are low. So a mechanical support system allows high procedural efficacy and hemodynamic protection, may allow bailout in emergencies, although maybe at the expense of an increased risk of using the system, and a risk score such as the pain ESD score may be a useful score to identify high-risk patients who might benefit from prophylactic implantation. On the downside, of course, although these procedural advantages exist, it is unknown whether this translates to an actual lower rate of long-term arrhythmia recurrence. And the authors also note that for particularly the pediatric population, VA ECMO is still the predominant system that is being used because of the fact that an Impella 2.5 device may not provide adequate support. In our center, this translates to a workflow where rescue device is available. We can use Impella or ECMO as needed, and we can use prophylactic support as an option in patients with VT or VF storm, or in those patients that undergo redo procedure where we have an upfront knowledge that there will be a need for VT mapping, that substrate mapping will not be sufficient. These are patients with either a deep focus or no identifiable substrate, or patients with a very diffuse substrate where the clinical VT is available and we want to specifically map and ablate that VT, or we have issues with transmural lesion formation. Indications currently, especially in most settings I know, and certainly for our center, indications are limited by budget constraints. And to finish up, I would like to show our setup. So this is what our lab looks like during a procedure. What you can see is ongoing VT. You can see on the anesthesia screen that blood pressure has dropped, that the blood pressure is a flat line. If you look closely, you can see end-tidal CO2, which is 29, which is very nicely preserved. And what we typically do during these procedures is monitor in real time the neurological perfusion. You can see that here, neurological perfusion, where in the green line you see a sharp drop, and it means something happened. It means we need to stop and we need to give the patient a break. Typically, it means the patient went to VF instead of VT, and you can see the correlate here as well in the spectrogram of the brain function, where you can see at the end of the spectrogram that suddenly brain function ceases, and then of course we know we need to stop the ongoing arrhythmia and let the patient recover. In conclusion, in our experience, percutaneous hemodynamic support for VT ablation is feasible. We see minimal interference with 3D mapping systems and have observed a high clinical success rate. We found that hemodynamic support for VT ablation in a prophylactic setting is safe. We use a dual percutaneous suture-mediated closure device, the ProGlide, to close after access. We use real-time neurological monitoring, as I've shown you, to ensure adequate brain perfusion during ongoing VT, and we have surgery backup present for all our cases. I think the use case for hemodynamic support in selected VT patients is intuitive. There is no doubt that it is a sensible thing to do in selected patients. However, randomized data is missing, and reimbursement typically requires this randomized data, which means currently we are hampered by a chicken and egg problem of not being able to provide this randomized data. So thank you very much for listening. That is what I wanted to share, and I suggest I stop sharing my screen so we can immediately move to Dr. Wakili, who will share his experiences in building a support program at your site, at which point I suppose we can take a few questions and go to our experts.
Thank you very much, Tom, for the introducing words and for this very nice presentation, giving us an overview for how the data situation is and how you are actually performing it. I want to add my presentation now to give you and try to give you an idea what we think is important to set up a complex VT program in our center, and what we think is required, what are the important variables or the parameters we should look on. The question I want to answer is which patients, and then I want to actually try to look in the therapy of VTs. Is it interdisciplinary? Is it multimodal? Is it interventional? And what's the role of VT ablation? How do we perform procedure planning and performing of the procedure? So the question is, which patients are we actually talking about? Like patients coming with ventricular tachycardia. And you see there are many entities which actually lead to a ventricular tachycardia. And I think the broad population are the patients with ischemic cardiomyopathy, then dilated cardiomyopathy. Then we have some patients after or during myocarditis, hypertrophic cardiomyopathy, sarcoidosis, RVC, amyloidosis, restrictive cardiomyopathy, and hereditary primary electrical disorders, like going down here with prevalence. I think the main two which I also want to focus on are the ischemic and non-ischemic cardiomyopathies, which actually are the patients which we currently treat the most with ablation. So if we look at these patients, we can actually, conclude that therapies and therapeutic options got a lot better during the last decade. And you see here one picture with an ICD, LVAD device, a lot of wires into the within this patient. This is another picture from our cath lab performing ablation. You see CRT device there, a mitral clip. So there are many options to treat patients with heart failure and cardiomyopathy, and the options got better and the patient survived. But by the patient surviving, other problems occur, like, for example, VTs, and the patients and the handling of the patients becomes more complex. So I still believe that if we talk about ventricular arrhythmia, that the main goal is still to treat the main underlying disease leading to VT. Either it's coronary artery disease, if it's heart failure, if it's valve disease, this remains the main goal. And the ablation, of course, is one therapeutic option, but never forget that there must be an underlying reason why this ventricular myocardium is actually electrical diseased. And if there is a chance to treat the underlying main disease, you have to do that. Therefore, I think if you put up a VT program, you have to work interdisciplinary. That means you need also an interventional cardiologist at your center, at your site, which is also able to look at the coronaries of this patient, the structural situation, structural heart situation of the patient. Maybe he requires a different art of therapy. Maybe he requires PCI. Maybe he requires a valve repairment. You need a heart failure specialist for best medical therapy. I think I would also consider any kind of assist devices. Is this a patient for transplant? This also should be taken into consideration when you're treating patients with VT with a concomitant cardiomyopathy. Of course, you also, and this is, I think, very important, and that's why I'm very happy that this circular report now more and more recognize that electrophysiologists also part of the team treating patients with heart failure and cardiomyopathy, especially when it comes to VTs. And already mentioned, we are treating the VTs by ablation. And of course, you have to have one heart surgeon in the team. Is it for any device implantation? Is it for a left ventricular assist device? Is it as a backup, as already mentioned? But there needs to be a team which is able to handle all the problems coming with this patient, coming with this disease, which actually led to the VT. This is guideline recommendations. I'm sorry, this is still German, but it comes as a dear translation from the priority guidelines. And if you look for the primary therapy, you will observe that catheter ablation is still the one major hallmark of VT therapy in these patients. But ablation alone might be not enough. That's one thing I just want to mention. Therefore, our management and our setup, how we actually approach this is that we say, okay, it's an intra but also interdisciplinary approach today. If you talk about the VT unit, this is adapted from Paulo Della Bella's vision. You need different specialties, including electrophysiology, including interventional cardiology. You need a specific heart failure program. You need a very good intensive care unit. You need, I think, also cardiac imaging, especially pre the procedure is important. You need a heart surgery department which is able to handle problems before and after, or also really contribute by device implantations. And you get a new anesthesiology stuff to put your patient at full sedation, and also accompanies the procedure of an ablation, especially if it comes to circulatory support systems. So actually, we are talking about a multimodal therapy. We have the acute problem, the acute management of the VTs by drugs or anything else. You need best medical therapy for the underlying disease. Catheter ablation is still a hallmark. You need a very good intensive care medicine, maybe during the acute phase of VTs, but also post-procedural management of these patients, because they are very sick patients with mostly severe impaired left ventricular function, and also other comorbidities, kidney dysfunction, and also really very, very complex other disease types. I think that pre-interventional imaging by MRI, CT, also what we use much more frequently in recent days is PET imaging, is something which can already guide you to the region of interest, whereas actually we are looking for where's the substrate located where we have to go to. I think device therapy is one thing which is for sure established: ICDs, pacemakers, subcutaneous ICDs. The therapy of the structural heart disease should be should be really looked on. Is there a patient with mitral valve disease or aortic stenosis or other things which we can actually improve to really improve the situation of the ventricle, and thereby also improve the precondition of the substrate which led to VT. I think you should have a team or a unit which is able to handle assist devices, implant assist devices, or handle them, and you should have a certain experience with circulatory support systems on the interventional basis, but also on the electrophysiology basis, to really keep the complications low and really keep your outcome at the highest level as possible. Because, as already mentioned by Tom, there is a certain benefit, but it comes probably at the cost of certain higher complication rates. Therefore, you should really have an established workflow and also an experienced team how to use these circulatory support system. And I think heart transplant, especially when it comes at young patients with end-stage heart failure with ventricular arrhythmias, is always an option you should look into rather earlier than too late. What's one of the problems? Already mentioned. If you have really a diseased ventricle like this one, probably you can imagine that you will have a very huge substrate. So the question is, if you go for substrate modification in these patients, where are you going to start? Where are you going to end? And as already mentioned, prior procedure duration comes at the cost of complication. So it would be really nice to have a focused area which we can actually go to and address the problem. And 69% of these VTs were actually unmappable due to hemodynamic intolerance. How was the peri-procedural mortality? 3%, 1-year mortality 18%, and the success rate pretty poor for treatment, 50%. These are data from Leipzig, from Gerd Hendricks Center. Mean left ventricular ejection fraction was 33%, intra-hospital mortality 4%. What about success rate? More or less the same in ischemic cardiomyopathy, 57%, in non-ischemic cardiomyopathy, 40% respectively after 1 year. So there's a lot of room for improvement. If we talk about complications, then we have to see that complications are actually pretty significantly associated with left ventricular ejection fraction in the other way around. Like, poor ejection fraction is associated with a high rate of major complications. You see here above 10% if you have an ejection fraction below 25%. And these patients are not really rare. There's a certain amount of these patients present. And then you really have to consider that you have a major complication rate of VT ablations if you go into this patient. This is also something mentioned by Tom before, the management of ventricular arrhythmias in the future. And this includes hemodynamic support in these patients. This is a picture of Impella 5.0. This is a really big device. We use the CP. Here you see an illustrative picture. This is like actually the rhythm. You see onset of VT and you see low output cardiogenic shock. If you really implant a circulatory support system, then actually you can maintain a certain flow, maintain circulatory sufficient circulatory of all the organs, including the brain, as already mentioned, and this enables you to perform a map during the ongoing VT and thereby improve probably the outcome and also reduce the complications later on of acute hemodynamic decompensation. So this is already mentioned, the pain ESD score. It's based on the McClinsky data. It's a point system with pulmonary disease, age, anesthesia required, ischemic cardiomyopathy, NIH class, ejection fraction, VT storm, and diabetes. In the end, there are 35 points. And if you go above 70 points, as already mentioned, the risk of acute hemodynamic decompensation is significantly increased up to 25%. So this should give you a red flag if you really reach over 70 or equal 70 points in a patient prior VT ablation. You should really consider prophylactic Impella placement. And these are again the data, and these were looked in patients VT ablation performed with a support system and without a support system. And you can see here that the rate of 12-month mortality, as already mentioned before, as well as acute hemodynamic compensation was severely increased in patients where the VT ablation was performed without a support system. This also encourages patients with a high risk should be really considered for a support system. Now, as I already mentioned, we think that VT management today is intra and interdisciplinary with the concept of VT unit. The patient arrives at the ER. Maybe you have a cardiac arrest center. Then you have to decide, is the patient going to intensive care unit, intermediate care unit, heart failure unit? Then you have to really set up an interdisciplinary plan for the patient. For example, we have a heart failure board meeting where an electrophysiologist is always present, interventionalist, a heart failure specialist, intensive care unit, heart surgeon, and a physiologist. And then we actually plan what is the underlying disease? Has he optimal medical drug treatment? Where we can improve something? Is this a patient for transplant, or is it a patient actually for an ablation? And if it comes to ablation, we have to plan the procedure. Do we require substrate imaging before? Do really that worse a substrate? You always, as already mentioned, vascular access complications are one thing of the Impella device. Always go there before. Look, how are the vascular situations in the groin? Is the patient actually suitable for an Impella device? And if no, be aware of that. And if yes, is there anything we can do before to lower the complications rate? Is the circulatory system actually required? Look at the pain ESD score. Is it equals or more than 70 points? You saw that the data really actually suggests that there's a high complication rate. So you should really consider a mechanical circular support system in these patients. Go for really a specified group of anesthesiologists, which are really, I would say, familiar with cardiac patients with impaired ventricular function, with circulatory reeling and needing catecholamine-like support. And the question you have to answer is, which mapping system are you going to use? You want to use a high-density mapping system? You want to use a mapping system which goes along with the circulatory mapping support? What is the best system for your patient and for the operator? And which cath lab is required? We always go for our hybrid OR, that we are really prepared for every situation. We have enough space for all the, I would say, for all the equipment. If we get in a really severe situation, we can always switch to heart surgery. So we always wanted to be prepared for the worst situation, but have the best preconditions available at hand. So I want to summarize and conclude. I think VTs are getting more and more common, and they are very relevant with respect to prognosis within a heart failure patient population. Patients becoming more and more complex with multiple problems, multiple devices, and therapy is going beyond on sole ablation, and it's an intra and interdisciplinary therapeutic approach with the concept of, I would say, VT unit. Nevertheless, ablation is still remains still one hallmark of therapy, but we have to really make sure that we have best preconditions available, and they are required to achieve the best outcome in this patient, also with respect to complication, peri-procedure and post-procedure. So use imaging, really consider mechanical circulatory support in these patients based on data in the literature. Look at your cath lab setup. Also, like Tom mentioned, like you really have the good setup, monitoring of neurological function, have a good anesthesiology, really be aware which mapping system are you using, and have the good stuff available, because at the end, everything matters. Thank you very much for your attention.
Thank you very much, Reza. I don't think we have burning questions yet, and I want to maximize the time we have available for our speakers. So I would suggest we switch to Dr. Ramana, who will share his experience based on a case illustration from The Hague. Please.
Thank you, Dr. De Potter. I really enjoyed both of your presentations, Dr. De Potter, Professor Waikili, and especially Dr. Waikili, the things you outlined. Yeah, I would say, yeah, we followed all that. And I wish I had seen your talk a couple of years ago before we started, because it would have saved us a lot of time. Let me start sharing here. Okay, now this is from a case we did a couple of months ago. Okay, there you go. Yeah. Okay, Now, this case, a 75-year-old patient, he had an old myocardial infarction, inferior wall, actually a little more than that. The PCI guys worked on him. In successive procedures, they extended four vessels. Despite that, his ejection fraction was 20%. He was put on heart failure medication. He was monitored by the heart failure people. He had a left bundle branch block, and we put in a CRTD by the device people. He had permanent AF, which was at the time left as is. And then a couple of years back, he presented with ventricular tachycardia. He was given amiodarone, and he had an endocardial ablation. That was about 3 years ago. And this was a substrate modification. He did not tolerate being in VT. And, that was a substrate modification, kept him going for about 3 years. And he presented in the ER with a pulseless VT. His ICD had detected it and had given therapy, but had exhausted its therapies. Of course, you could still look at the way it had been programmed, but he was successfully resuscitated. He had no neurological damage. And then during that he was admitted, he had multiple episodes of VT, and they shot up some extra IV amiodarone. They tried procainamide and didn't work, and something clearly had to be done. He was on medication, fenprocumon, which is a kind of long-acting warfarin, bumetanide. You have the sacubitril, valsartan, the ARNI. He was on propranolol as a beta blocker. He was on the SGLT2 inhibitor. He was also on amiodarone. The amiodarone levels 1.5, 1.2. You could increase on that, but it was felt that something needed to be done. As you can see, the heart failure medication, pretty much state of the art. The heart failure guys do that. And we tried to image him with MRI. We could not. So this is the echo. And you can see that pretty much only this area of the left ventricle is okay. This part's bad. This part's bad. So a very large substrate. And we actually felt that, this is one of the VTs he had. You can see the superiorly directed axis, signifying that it's from the inferior part. And if it was a redo case, as Dr. Potter already had shown, we would like to do a procedure and map the VT, at least be able to do that. So then, of course, we whip out this card, which comes in really handy, and we use the pain ESD score. And of course, there is a budgetary constraint, because if you say the word Impella, I want to do an Impella, then the management always goes, "Oh no, we can't do that," because it's expensive. If you show them this convinces them. If you have of course, there's two kinds of pain ESD scores: one with anesthesia included and one excluded. And as we always do the case with anesthesia, we use the score where the anesthesia is disregarded, the pain ESD with only one A instead of the one with two A. So if you're above 15, then there's a 24% chance of decompensation during the procedure. And sorry about that. And if someone goes into decompensation, there's a 50% chance of mortality acutely. So if you let's look at it in this case. This patient, he did not have COPD, which was good. His age was above 60. He has ischemic cardiomyopathy. It's 6 points. A New York Heart Association class 3 or 4. Well, of course, when he was in VT, yeah, but when he was out in VT, he was at least 2. So no points for that. Ejection fraction below 25%, 3 points. VT storm. Well, he had a couple of episodes, but VT storm, I would think, would be someone who was under anesthesia with almost incessant VT. So that's doubtful whether he had that. For the sake of argument, let's leave that out. He had type 2 diabetes, so in total he has 15 points. So we opted to do a procedure, general anesthesia, with a cardiac anesthesiologist. So that's an anesthesiologist who does bypass procedures and that kind of stuff. And we decided to go for an approach using Impella support. And we decided to do both an endocardial and have the option to go for an epicardial approach, because at the substrate ablation, the previous procedure, it was felt that there was not, really identifiable substrate on the inside, and what was identified had been ablated. So it was decided that we would have to have the option of also going in epicardially. So in this case, it's kind of funny. If you look at the RAO here, this is the RAO fluoroscopy. You have the atrial lead, you have the LV lead, you have the RA lead. the shock lead. And then there's this. It was not visible on the chest film because it was it was not really visible. But what you can see is that the LV lead is prolapsing into the right ventricle, and at the time, it was felt that maybe that's causing the VT, and so there was a bit of discussion. So then we decided, okay, let's move it out of the way. We just snared it with an ablation catheter. We have done that a couple of times, and just pull it into the cava. But then with only one extra stimulus, we were still able to induce the VT. So we decided to continue with the procedure. Now, this is might be a bit confusing picture, but here this is the setup. We have one catheter coming in epicardially, anterior approach with the HG grid catheter here. We were using an Insight X mapping system, which is not susceptible to any magnetic distortion from the Impella device. There's a transeptal sheath here to go in endocardially, in addition to the right ventricular shock lead here seen in the LAO, the transeptal sheath, the Impella coming in, and here on the outside, the high density mapping catheter. Now on the inside, it's better not to use the HD mapping catheter, as it could get caught on the pigtail that is on the Impella. We were able to induce the ventricular tachycardia and then replace the HG grid catheter with the ablation catheter. And we actually found a large channel on the epicardium, and we were able to entrain the VT there. We were able to demonstrate that it was a critical isthmus, and the ablation there, RF terminated the VT. And ever since, the patient has been VT free, and he's been doing really well. He's now monitored by the heart failure department and by the device department, and he's doing really well. So in this case, the case was rendered non-inducible. The femoral access site was closed with using a suture-mediated closure device. He was given triamcinolone acetate intrapericardially, and he made it uneventful recovery, no VT. So he remained stable during the procedure, and the VT could be successfully ablated. Now, a couple of things that we need to discuss here is, of course, there is the chance of getting access site complications. We always do a CT scan first, where we scan the groin vessels and also the abdominal aorta. And we do get the vascular access using ultrasound. I never used to do that previously, but these days we do it. And you make sure that you're doing your puncture in the common femoral artery and that you get a clean stick. And that really helps get the complications down. We had a single case where the groin vessels were not usable. And we had the cardiac surgeon, who is also standby, do a cut down on the right axillary artery, and then which they use for TAVR and that kind of procedures. So they're used to that. So that can also be used in selected cases. Thank you.
Thank you very much for this talk. And I think it's really nice how you also put this together, what we all previously said, that it's a whole managing of things which you have to consider if we do that in such patients which are really complex. I would actually suggest that we go on with the next talk and then have a common discussion later on all the talks. I think that would make sense. Therefore, it's my pleasure to introduce Tamas to his talk. And he's talking about robotic VT ablation with MCS support. And we're really looking forward to really probably impressing pictures, impressing really illustrations, how you perform your VT cases in Rotterdam.
Thank you very much for the kind introduction, and also for the invitation that we can share a case with you guys today. And indeed, I think it's an interesting topic, and I would like to show a major dilemma of us in many times when we select patients for different kind of VT ablations, because our preferred approach is a robotic approach. And it's not coming for nothing. So this is the center where the Niobe system was installed in 2003 already. And we did over 2,000 magnetic navigation procedures overall, including a few interventional procedures at the beginning. And we have also areas of interest in terms of research. And here you can see but one of them is the ablation of ventricular tachycardia. So we collected data continuously during those years, and we were actually convinced ourselves that this is the way to go, at least for us. Now, when I put it a little bit in a broader perspective, for us, we all work continuously since decades to improve catheter ablations, and obviously in a VT ablations we can improve efficacy to a certain extent. Lab efficiencies can be improved as well. We have problems with reproducibility. We still know that there are really good VT ablators and there are less good VT ablators in every country. And again, safety, all of you mentioned today that it's a major concern, especially in this very vulnerable patient population. So many of those are actually addressed by the use of magnetic navigation system, by its atraumatic flexible catheter design, the unrestricted catheter navigation, the reproducibility of the magnetic vectors, enhanced stability. And in most of the publications we and some other groups presented, it was associated with less fluoro time, which is, of course, for us, for operators, is also very important. Here you see the major difference between manually guided catheters and magnetic navigation. So in here, the right upper corner, you see the so-called constant contact. So with this catheter, it's almost like a front-wheel drive car. The tip of the catheter just sticks on the wall of the heart. That can be an advantage in many chambers. I can speak only for ourselves. So when we looked at already in 2012 our own manual and magnetic procedures, we really had a higher success rate with magnetic navigation in our own hands. And what we also liked in terms of lab efficiency, we could decrease procedure times, fluoro times, and application times by using this. So we really prefer this one, and I'm not the only one in the group. It is very interesting. I'm working with 5 EPs, and we have some differences in terms of atrial fibrillation, but in VT, I think most of my colleagues agree, and actually all of them, that this is a superior system. We all know that the contact force catheters were coming into the picture later in the last 10 years, and we reanalyzed our data, and interestingly enough, the remote magnetic navigation remained superior, and the contact force, using a contact force in the VT ablation didn't add anything to the previously used manual catheters. So what is the dilemma? I can tell you that I had to do a case 2 or 3 weeks ago. It was a redo ablation for LVAD patient. And we know that for the LVAD, we actually cannot use the magnetic navigation because it doesn't work. So should I use then a manual ablation without the advantage of the robotic magnetic navigation that we developed in the last 20 years? Or should I use robotic ablation but without optimal hemodynamics? Of course, in an LVAD, it was not a question because I cannot remove it. So I had to do it manually, and I suffered enough, I can tell you. But for other patients, when we need mechanical support, I was very curious whether we can implement the Impella, and this is one of the take-home message today, that we pre-tested it in the magnetic lab, and then we did quite a few patients in the last years, not enough, unfortunately, due to the financial considerations, but I would use much more, of course, if it would be better reimbursed in our country. And I choose for the mechanical support with robotics when I have the Impella device. And I put here one more thing. I hope I can show you at the end one slide. We have some difficult grown-up congenital heart patients which doesn't have VTs, but they are suffering from SVTs, but also hemodynamically unstable. And I think we were the first group presenting the positive effect of Impella in these cases in a univentricular physiology hearts. So the patient I would like to show to you to guide through this procedure, how we do it and what differences we have with the manual ablations, is a patient with an ischemic VT, 67-year-old with a long history of ischemic heart disease, PCIs, and infarcts in the past, even stent occlusion 2 years later, and he has a very poor left ventricular ejection fraction. And in 2008, he received the VVI ICD. And in 2018, an upgrade to CRT. And in the same year, he developed sustained frequent VTs, many morphologies on the ECG. And the first attempt of manual ablation was unsuccessful because of hemodynamically unstable VTs. So it's really something what you all mentioned before, that these patients are out there. He was on amiodarone and he has some non-cardiac diseases as well. Now the way how we do it, similarly to you guys, I just try to move further. Indeed, we also perform the punctures echo-guided, at least most of us, except me. I'm too old for that, sorry to tell you, but the whole team actually prefers this, and then I completely agree with you, with them to use it. But what I would like to show you here is the setup of the lab. What you could see already in the previous movie. I just stopped this for a moment. So we have fully equipped labs available in all of the labs, including in a robotic lab. And here you can see and then you don't need to exchange it anymore. Here you see very nicely, my colleague is puncturing the septum and then pushing through the edgeless sheath. It is even safer, I think, because after puncturing, you put the guide wire immediately into the, you can just put through the catheter. Then we have a choice. In this case, we also tend to do a high-density map with multi-electrode mapping. In this case, with Pentaray, because for VTs we prefer the CARTO, but that also means that we are not able to use the magnetic navigation at that stage. So I would call it more like a hybrid, can be maneuvered only manually. I show you image. Please try to remember this, because it shows very elegantly in the next movie why we actually use the magnetic navigation. At that stage, what we also do, we induce the tachycardia and we try to learn as much as possible about this tachycardia. So this is the stage when we can even decide ad hoc to use the device. So if we have a hemodynamically unstable VT, then we go for the Impella device. Otherwise, if we have a hemodynamically stable VT or many VTs, then we go for the standard procedure. In this case, we had hemodynamically unstable VTs, and here you see the difference. So in the lab, you have the big magnets. These are permanent magnets providing zero brought into the patient area, and therefore we have to adjust the location of the pads. You can see here the CARTO patches. They have to be positioned slightly differently because of that. And you see that, of course, we try to put the Impella device as far as possible from the magnets. Here, I wrote something downstairs, that collaboration with the interventionist. It is interesting in our lab. we always ask the interventional cardiologist to put the Impella device into the heart, and they also remove and they do the closure. This is because they are very experienced in arterial access sites. I think it's a very wise method. It's not that we cannot puncture. For instance, I do most of my ablations still retrogradely. But I think for these big devices, those people can make the difference. So at that stage, we reassess the hemodynamics. We make sure that it works. So, for instance, here is the X-ray image. Everything is in. Patient in sinus rhythm, and then we induce the tachycardia again, and then you can see that indeed it was a very good idea to use the Impella because it's a flat line but with a good mean arterial pressure. This is how the ablation mapping with an ablation catheter looks like, and I indicated here the most important thing for my electrophysiologist colleagues. So one of the reasons why we use this catheter is this. I would call it a reach, because you saw this initial image, and now I fine-tuned the map with a robotic catheter, and what you can see at places where we thought using the Panther-Ray that there is a scar, I can obviously reach. I have a better reach for different parts of the left ventricle, and you see that in terms of size, it became much smaller. Actually, this guy has a much smaller scar than we thought at the beginning. On the other side, what you can see is the end result. This is a combined approach. So we tried to do the ablation during VT. And in this patient, we had 5-6 VTs, and we always re-induce. We have the Impella, so it's very safe. But we tried to terminate all of the VTs during ablation. And at the end of the day, when we cannot induce the VTs anymore, then we go for a full scar homogenization. You may ask why I do a kind of hybrid ablation, scar homogenization and mapping and ablating during VT. It is something to do with the fact that in the past I had many times patients when I left even fast non-sustained VTs untreated, and then finally those were coming back clinically. So I really want to make sure, even with this exaggerated method, that the patient is on the table last time. And as I said last slide, it's nothing to do with the VT ablation, but we used also this in Fontan circulation patients. And here I would like to draw attention to what, with another very important aspect of using this device, is the importance of preload. When you use the Impella in those patients, even after the introduction of the support, you don't get good mean pressure until you correct the preload. So it's very important, if you use it in a univentricular physiology, that you first correct for the preload, and then you can stabilize the patient. And these patients even getting unstable and cyanotic within 100